My name is Dr. Petroska. I'm a first-year internal medicine resident at Mount Sinai Medical Center, and today I would like to present the case of slow but not steady transthyretin amyloid cardiomyopathy that presented with atrial fibrillation with slow ventricular response. Transthyretin amyloid cardiomyopathy is a cause of restricted cardiomyopathy that is caused by accumulation of misfolded transthyretin protein in the myocardium that forms insoluble amyloid fibers and makes myocardium stiff and rigid. This causes decreased ventricular compliance, then in turn causes diastolic dysfunction with increase in left ventricular and diastolic pressure, as well as left atrial pressure. This increased atrial pressure increases the likelihood of atrial arrhythmias, and the myocardial infiltration itself often affects the electrical conduction system of the heart and presents as a heart block. Here we present the case of transthyretin amyloid cardiomyopathy that was discovered in an asymptomatic patient with atrial fibrillation with slow ventricular response. Our patient is a 90-year-old white female with history of hypertension, hyperlipidemia, insulin-dependent diabetes, and paroxysmal atrial fibrillation. She presented to emergency department due to low heart rate in 40s that were noted by a home health aide. She noted that 2 weeks prior to admission, patient felt dizzy and had a fall, however did not lose consciousness. On physical exam, only pediments were bradycardia and bruising from the fall. There was a mild flash troponin elevation with NT-proBNP elevation. On EKG, there was atrial fibrillation with slow ventricular response, left axis deviation, as well as left vesicular block. Next, we obtained transthoracic echocardiogram, which revealed mildly impaired left ventricular systolic function with ejection fraction between 45 to 50%, with severe asymptomatic interventricular septal hypertrophy without evidence of obstruction. There was also abnormal signal intensity, a speckle pattern of the hypertrophic left ventricular wall segments that you can appreciate in the figure 1. We have a prior echo from 3 years before that did not have those findings of hypertrophy and a normal ejection fraction of 65 to 70%. We obtained urine and serum electrophoresis as well as serum kappa lambda ratio that were all within normal limits. The next step, we got nuclear medicine of cardiac amyloid pyrophosphate scan that show elevated heart to contralateral ratio of 1.7 with diffuse myocardial uptake, which was graded as a grade 3, which was strongly suggestive of cardiac amyloidosis. In the figure 2, you can appreciate the grading system. A grade 3 means there's a cardiac uptake greater than the rib uptake with either mild to absent rib uptake. And figure 3 shows the results of our patient. Our patient and the family decided that they do not want to pursue pacemaker replacement, and patient was discharged home in stable condition with outpatient cardiology follow-up. So what makes this case interesting? Our patient highlights the broad range of presentation when it comes to cardiac amyloidosis. Her EKG and echo already raised suspicion, and given that the EKG demonstrates atrial fibrillation with slow ventricular response, this can be expected given the propensity of atrial arrhythmias and conduction system blocks. In this case, tissue biopsy was not necessary in patients with grades 2 or 3 or with elevated ratio above 1.5, and our patient had 1.7. The biopsy is not necessary to make the diagnosis. The treatment includes tafamidis, which prevents misfolding on transthyretin, as well as other small interfering RNA molecules that interfere with expression of the transthyretin gene. The treatment also involves heart failure management. Diuretics are great for volume management. However, unlike the patient with heart failure with reduced ejection fraction, there is no evidence that ACE inhibitors, ARBs, or ARNI improve outcomes that may actually worsen autonomic dysfunction. Many of the patients also don't tolerate beta blockers. So given this specific in management, a timely diagnosis is extremely important in patient prognosis. And here in the figure 4, you can appreciate the diagnostic algorithm we follow for the workup of cardiac amyloidosis. Thank you for your time, and I hope you enjoy this presentation.